So okay, I want everyone to switch on their mic lah, if possible. Okay. What we are going to do today is basically we'll try and okay. So again, I will always tell this. This is not ideal. We are not living in an ideal situation. We are not living. We are not living in an ideal world currently. So as medical students, you should learn with your patient. You should learn by seeing your patients. Medical students, doctors, you learn by treating patient, seeing patient, meeting patient, clerking patients. This is how medical students should learn. And this, whatever this is not how medical, this has never been part of any medical education since before Ibn Sina. This has never been. So medical education should always be a face-to-face, a hands-on type of teaching. There are history where medical students even cut off their hands because of surgery, because of learning how to do surgery and things. So this is how we learn. Francis Crick, when he found DNA particles, he's just a medical student. So this is so medical students should learn hands-on. This is in no way an ideal medical education. But well, again, we are not living in an ideal world. We are living in a I don't know what to call lah. I don't know what to call. This is a weird world we are living in. All right. So okay. So now we are discussing. We are going to discuss about how to approach certain cases based on the problem. Okay. I know you guys have not had any proper patient contact, but that's fine. Okay. So I'll give you a scenario, and what I want from everyone is one by one lah. Kita ikut flow dalam ni kan. You guys tell me what are the informations you want to know. So what we want to learn today is actually how to approach certain complaints from patient. Okay. Alright. So on my list, the first one is Rukniyatil Husna. Lepas tu Wan Nabilah, dua nama dia. Wan Nabiha. Lepas tu Nur Nabilah. Wan Nabiha, lepas tu Nur Nabilah. Lepas tu Abdullah Hakim, lepas tu Ikhwan, lepas tu Afiq, lepas tu Aida, lepas tu Hanis Hamdan dan Aminah. So remember your flow Okay, Aci Mak Labu. Okay, alright, fine. So the problem that I wanted to discuss with you is a child that presents with rapid breathing. So what are we go one by one, we go by system, we go by history. What are the history that you would want to know? The first thing that I tell you, this is a child presenting with rapid breathing. What are the information that you would want to know? So one by one, bagi satu point.
Berapa hari, doktor?
Satu. That will be the question. So ask what are the, I want to know what are the questions that you would want to ask. What are the information that you would want to ask? So we begin with history first. What are the history or what are the symptoms that you want to know? Symptoms, history, it means everything in terms of history. And then we go to physical examination. Okay. All right. Fine. Okay. Start with, panggil apa ni? Husna. Husna. Right.
I will ask the patient when did the rapid breathing start at first?
2 days prior to admission. Okay, all right. Next, Nabiha.
Do the rapid breathing come with fever?
Fever, yes, there is fever.
Any exposed to any allergen because it could be infection?
No history of exposure to allergen.
Any other family members that have similar symptoms?
Currently no. Currently no. So what is your question actually? Is it, do you want to know just family member? What actually what are you trying to get from your question, Abdullah?
The contact of the patient.
So seek contact.
Yeah.
So the point should be seek contact, any seek contact, because children or patients, the contact is not just family members. You need to remember that, because if you ask just family members, the child can get the infection from someone else, from someone at school, from someone somewhere. So the question should be, is there any sick contact? Ada jumpa siapa-siapa tak sihat tak? Mungkin jiran is not family member. Mungkin family friend is not family. So if you ask question very specific, very close, kan? You tutup you punya question tu, family member saja, then you won't get the answer that you would want. Kan? Kalau you tanya ada parents unwell tak? Then you are excluding the siblings. Faham tak? So broaden your question. So again, in medical, ideally you should give open-ended questions, but in many cases you need to do targeted open-ended questions. And sometimes you do need to have close-ended question. Close-ended question ni maknanya ada batuk tak? Tu close-ended. Kan? Kalau open-ended ni macam ada tak tanda-tanda masalah pernafasan yang lain contohnya. So you are targeting it to pernafasan punya issue, tapi it's close. It's still open. Faham? So you give the answer other than yes or no. So those are targeted open-ended question. Okay. Alright. So yes, you need to ask about unwell family members, but kalau macam AGE, so you nak tahu more family members. But AGE pun you still nak tahu juga school ke, kat mana ke, apa ke. So far no one ask me age lagi. Kan? So now I'm telling lah. So age of the child is 4 years old. Kan? So you need to what I'm trying to say is you need to open it up. Do not close it too much. Okay? Sometimes you do need to close it, but mostly is you buka dulu, lepas tu kalau tak dapat apa yang you nak, baru you target and you close. Faham? Alright. Fine. Okay. Ikhwan.
Maybe the characteristic of fever itself. If it is high grade fever, might suggest pneumonia, and if it's low grade fever, bronchiolitis. But the age 4 years, right? So it can be ruled out bronchiolitis because bronchiolitis less than 2 years usually.
So pneumonia cannot be low grade.
As I'm not sure that. But
so
must come with.
Can is never a good question. If I ask can or cannot, the answer is always can. So obviously, if the child has viral pneumonia, for example, or atypical pneumonia, for example, it won't be a high grade type of fever, isn't it? It will be low grade type of fever. So bacterial pneumonia, that is high grade fever. Okay. All right. Fine. Afiq.
And the bacteria is most worst prognosis, right, doctor?
Not necessarily. Don't forget about TB. Don't forget about PCP, pneumocystis carinii pneumonia, or nama baru dia is pneumocystis jirovecii. Kan?
Okay.
Don't forget about aspergillosis. Don't forget about yang lain simple lah sikit. Don't forget about pneumonitis. Okay. Alright. Fine. Afiq.
If the patient has a cough?
Yes, cough. What should be your next question after that?
The character of the cough. Is it productive or dry cough?
Okay, alright. So productive cough. What is the next question after that?
The color of the sputum.
Color of the sputum. Okay, I'm gonna ask you. Can can a 4-year-old expectorate?
It's quite difficult.
It's quite difficult. So 4 years old, you don't expect the child to cough out, putum, kan? Batuk keluarkan kahak. 4 years old cannot do that. After 7 years old, then probably can. Even that is difficult, kan? Medical student also difficult to get cough, putum, kan? So so 4 years old is not going to be easy to expectorate. So your next question is, you should ask how that the parents know that it is productive cough. Is it just by the sound of the cough tu bunyi wet cough, or is there any apa macam mana lagi you nak tahu color of the sputum?
Bingus dia.
Huh? Ingus, okay, fine. Lain daripada tu? What happens with a patient with cough? What can happen that will allow you to see the color of the sputum? Vomiting. So children, what they do
associate with
associate with apa Ikwan was trying to say something.
associate with vomiting or nausea or not.
So post-tussive vomiting, post-tussive or post-tussive vomiting. Maknanya post coughing. Dia cough. Setiap kali dia cough, dia telan. Dia cough, dia telan. Dia cough, dia telan. So bila dia telan, all this sputum, all this gunk, it gets into the stomach. And all this gunk, this mucus, everything, it doesn't pass through the stomach well. So di build up dalam stomach. By time dia akan keluar as a vomiting. So usually it's a post-tussive vomiting. Dia cough and then dia vomit, and then you can see the sputum. Alright. Next, Aida.
Can I ask more about the rapid breathing? Like, for example, is it on exertion or is it on rest?
It's more on exertion. At rest pun ada, on exertion it get worse. What should be your next question? Aida, what should be your next question?
Is there anything that stops the rapid breathing, like rest?
So your next question should be, what is the severity of the exertion? Is it mild exertion, or is it moderate exertion, or is it memang exertion teruk, panjat tangga 3 tingkat 5 tingkat baru ada shortness of breath? Faham tak? That should be, you need to assess the severity of the exertion. But what was the question that you wanted to ask just now?
Something that helps with rapid breathing.
So the question should be, when the child is having that rapid breathing, what did the parents do? Kan? Betul? What did so the parents didn't do anything, straight away brought to the hospital. Okay, next, Hanis.
If the child have problem with feeding or drinking?
So there's reduced oral intake.
Is there any reduce of oral intake?
What else? Aminah.
I'd like to ask if the patient has any rash or
no rash.
Okay.
Husna, back to you.
I will want to continue to ask about the rapid breathing. Is it any history of previous same symptom?
Oh yes, multiple. Almost once every few months. This year alone already 4 times. Okay, Nabiha. So Husna, what should be your next question?
What kind of medical attention? Did apa salah ni? Ada bawa pergi hospital ke?
Okay, so the question should be, so you ask about any previous similar symptom. So first you need to ask the trigger. What are the triggers on the previous symptoms? Kan, dia jadi rapid breathing before sebelum ni. What are the triggers? Is it another infection or is it some other triggers that cause all this previous episode? And then the second question should be, did they seek any medical treatment? What did they do? What was the treatment given? Okay. So the answer would be previously all begins with some sort of viral illness, low grade fever, and then some cough, and then rapid breathing. And they always went to clinic and was given nebulization. Okay, all right, Nabiha.
Before that, the sex of the child.
Male.
Yes. And after that,
Okay, sorry. Where we are?
me.
Apa tadi?
I want to ask when the parents started to notice the symptoms of rapid breathing.
Since 2 years ago. This current problem ke apa?
I changed my question.
Sudah.
Do the child goes to preschool or any crowd place?
Nursery, yes.
Nursery.
Kindergarten. For kindergarten. Nabiha, why do you ask that question?
Because viral pneumonia are more likely to happen in overcrowded places.
Okay, my question to you, Nabiha.
Yes.
How frequent can a child get viral URTI per year?
Viral.
URTI, how frequent? You nak kata, oh, this is abnormal. Is it common for a child to get URTI?
Yes.
It's common, yes, it's common. Okay. So my question is, how common is common? How many URTI can a child have per year? Before you say, oh no, this is abnormal, we must investigate for something.
Common is common.
What is that something? Something yang you worried? Yang kalau frequent sangat dia punya dapat infection ni. What are you worried about?
Overcrowding place, macam kindergarten. Maybe there are other child who come.
Anyone ada answer lain? What are we worried of when a child has very frequent infection?
Immunization?
Immunocompromise.
Yes. Immunodeficiency. A child with immunodeficiency, they can get infection very, very frequent. Okay, so my question is, how frequent is frequent? How many URTI can a child have per year? So a child with exposure, a child yang pergi kindergarten for example, they may get up to 10 to 12 times viral URTI per year, and that is considered as acceptable. So bila yang kita kata it is unacceptable, yang kita kena work up for primary immunodeficiency, PID. There are some red herrings for PID. If a child presents with these symptoms, kita kena work up untuk PID. What are those? Anyone has any idea? So the red herrings for PIDs are such as 2 or more deep-seated abscesses per year, 2 or more septicemia per year, 2 or more pneumonias, severe pneumonias needing IV antibiotic per year, 2 or more otitis medias per year. So if a child presents with this red herrings, these symptoms, you need to investigate for primary immunodeficiency. Okay, all right, fine. Okay, so this patient has risk going to kindergarten. All right, Nabila.
Wait. Does the rapid breathing comes with sweating?
No. Why? Why are you
Because
asking?
it is one of the signs of respiratory distress. No, not significant.
Not significant. Dia melompat-lompat pun akan keluar sweat. Okay, alright, Abdullah.
Does the child ever wake up at night from breathlessness?
The child had difficulty in sleeping overnight. Because of rapid breathing. Okay, Abdullah dah kan? Ikhwan?
Yes.
Ha? Tak dengar Ikhwan.
Hello.
Ha, apa? What's your question?
Yes. Yang cough tadi tu dia apa tu dia punya karakteristik cough tu dah kita tahu ada test apa produktif or not.
Tidur. Lagi soalan lain apa?
Dry cough or
Wet cough, produktif. Afiq ke tanya tadi, kan?
Oh, dah tanya dah.
Tidur. Cepat, soalan lain.
Family history of apa ni? Any family history
Of apa? Family history of apa?
of asthma,
Asma lagi apa lagi?
atopy,
Lagi? So both parents had asthma.
yeah,
Yeah. Alright, Afiq.
mostly suggest
Apa? Afiq, next.
Does he presents with chest pain?
No chest pain. Sekejap, Ikhwan. Okay. So what are you trying to get actually tadi? What are you trying to get?
yeah, if apa the first relative has same no same macam ada asthma tu might very suggest
So
asthma.
you are assessing the risk of the child getting asthma.
Yes.
There is a name of this for this line of questioning. Nama dia apa? Asthma Predictive Index, API. Have you heard of API? So asthma predictive index, dia ada major factor and minor risk factor. Kan? Dia ada major dengan minor. So major, for example, doctor diagnose parental asthma, doctor diagnose allergic rhinitis in the parents, or the child himself has eczema. So these are part of major criteria. Minor criteria such as eosinophilia, such as a family history of atopy. So these are asthma predictive index. Okay, right, fine. Aida.
So in this patient, minor.
Major, both parents medically diagnosed asthma on treatment. Aida. Aida.
Yes.
Hmm.
Yeah. Can you hear me?
Yeah.
Do you see any difference in your child? Like for example, he's being more irritable.
No change in behavior. Ngantuk lah aku layan korang semua cepat. Hanis.
I would like to ask about the travel history.
No history of recent travelling. KP.
Okay, because if for this COVID era, maybe that family go to the place that high risk to get COVID, so we can expect that patient to have COVID.
Okay, alright. Aminah.
Does the child have a sore throat?
Yes.
Okay.
Okay, alright. So we've all asked questions. So now, let's go to physical examination. What are the physical examination that you would want to elicit? Let's begin with Husna.
Is wait. For general examination, I will see if the patient is alert or appear lethargic.
Okay, patient is alert, lethargic because acute. Okay, Nabiha.
So if there are failure or cyanosis.
There's no pelo, no cyanosis.
Presence of rash?
There's no rash.
Vital signs, body
Signs
temperature.
of nest.
Siapa ni? Siapa yang turn ni? Abdullah.
Nah, saya.
Apa soalan kau?
Body temperature.
Temperature 37.8. Still tak boleh masuk TMG lah.
Signs of respiratory distress.
There is. What are the signs that you are trying to look for?
The kidney, nasal flaring.
Apa tadi? Tachypneic. Okay. Okay, tachypneic. Nasal flaring.
Tachypneic.
Okay. Respiratory rate 40.
Grunting.
Normal ke abnormal?
Ada?
Respiratory rate 40. Normal ke abnormal?
If 1 to 4 years Kalau 4 years tak normal.
Abnormal lah, tachypneic. Okay, what are the other signs? You kata nasal flaring. Okay, ada some nasal flaring. Lagi apa lagi?
Grunting.
There's no grunting. What is grunting? Janganlah mute kan, Ikuan. Tak habis lagi. What is grunting? Mana siapa tadi? Ikuan kan? We lost Ikuan. What is grunting? Janganlah Google. Mana ni? Bukan Ikuan ke?
Ni apa ni? Hidung tersumbat.
Grunting. Apa grunting? What is grunting?
Hidung tersumbat.
No. No.
Dengkul ke doktor?
No, berdengkur is snoring. This is grunting.
Mengerang.
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 Okay, lebih kurang lah. Mengerang ni is difficult term. Grunting ni dia macam basically what the child is trying to do is they increase kind of the intrathoracic pressure. You close the vocal cord, macam you buang air. You close the vocal cord, you tegan. That is grunting. So contohnya, certain type of diseases, respiratory RDS for example, dia ada banyak lung collapse. So apa dia buat? Dia increasekan intrathoracic pressure. Bila dia increasekan intrathoracic pressure, dia akan bukakan lung, dia akan open up the lung field. So dengan cara dia buat macam ni, dengan increasing intrathoracic pressure, dengan dia close the vocal cord and dia terat. So this is grunting. It is a sign of respiratory distress. Okay, apa lagi? Signs of respiratory distress.
Use of accessory muscle.
Which accessory muscles?
Yes.
Huh? Which accessory muscle?
On the chest.
Hey, lah, memang on the chest, takkan on the foot. Which part of the chest? Which part of the chest?
External intercostal muscle.
Okay, intercostal muscle. Siapa jawab tu tadi?
Afiq.
Huh?
Afiq.
Afiq. So intercostal muscle, lagi mana lagi muscle yang affected?
Scalene muscle.
Huh?
Scalene.
Scalene muscle. Kat mana tu?
At the neck.
Scalene muscle? Are you sure nama dia scalene?
What about the diaphragm, doctor?
Huh? What about the diaphragm? Can you see diaphragmatic contraction?
In subcostal recession, is it the diaphragm that shows that, you know, the shape?
Okay. Where is the diaphragm inserted? Where is the insertion of diaphragm? Diaphragm insertion is at the level of T10. Where is your subcostal margin? Where is subcostal margin? Is below which thoracic rib?
The 9, 10, 11,
It's part of T12, T11. You have two hanging ribs, kan? T12 and T11, those are hanging ribs. You have the T10. So subcostal region is actually below your T12, T11, and also T10. Those are subcostal region. Okay, so when you breathe, what are the main muscles of respiration?
The diaphragm and the intercostals.
So your diaphragm is your main muscle of respiration. That's number one. Number wahid. Kan? Number two are the intercostal muscles and also your abdominal wall muscle. Because especially with men, we breathe abdominothoracic respiration. Female generally is more of thoraco-abdominal type of respiration. Newborn babies almost all breathe using abdominothoracic respiration. So we use our abdominal wall muscle. So in subcostal recession, is that the abdomen is the one that causing the subcostal recession, the abdominal wall, and also the hyper expansion of the chest. This is the one that causes the subcostal recession. Okay, I told you just now. Diaphragm is insertion of diaphragm is at the T10 level. Okay, so in a patient that has chronic asthma, frequent episode of respiratory distress, what are the clinical findings that you may see? What are the clinical findings you may see in chronic uncontrolled asthma? Almost the same as COPD and so on and so forth.
Hyperexpansion of the chest.
Hyperexpansion of the chest, or is there a name for it?
Barrel chest.
Barrel chest. So increase AP diameter of the chest. Huh?
Mm.
And not just hyperexpansion, it's basically increase AP diameter of the chest, which is barrel chest. Yes. Okay, lagi. What else?
Inflated chest.
Huh?
Hyperinflated chest.
Sama lah, hyperinflated tadi, barrel chest. Tak dengar ke? Tidur ikuan ni. Betul. What else?
Harrison Sarkis.
Harrison Sarkis. Yes, exactly the one I'm waiting for. So what is Harrison Sarkis? Where is Harrison Sarkis? What the heck is Harrison Sarkis?
The sarcus between that's formed between the sternum.
Sarkis between the sternum?
Eh.
Wrong lah kan?
Groove at the lower end of the cage.
Groove at the end of the rib cage? Wrong? Siapa lagi ada idea? There must be a reason why I'm waiting for this answer just after I mentioned about diaphragm, kan?
Depression on the chest.
So dia ada induration, ada depression dekat chest at the T10 level.
Yes.
Dia tenggelam dekat T10 level and then dia keluar balik dekat T11 and T12. So kenapa dia tenggelam dekat T10? I mentioned just now. Because T10 is the level where your diaphragm is inserted. Insertion of diaphragm. Diaphragm tu bersambung dekat level of T10. So bila dia banyak kali tachypneic, banyak kali distress, dia banyak kali diaphragm contact, so the T10 is indurated inside, pulled inside. Because of it's the where insertion of your diaphragm. If there is Harrison Sarkis, maknanya kerap sangat kali jadi respiratory distress. Okay, alright, fine. Okay, apa lagi physical finding you nak cari? Sampai siapa dah tadi ni?
Oxygen saturation of the patient.
Okay, good. Okay, alright. SpO2 is 91% in air. What is the significance of your questions, Aida?
To know like if the patient is having mild, moderate, or severe asthma.
Okay. You are trying to assess the severity of the asthma exacerbation. Good. Okay. What are the other features for you to differentiate between mild, moderate, severe, and acute and life-threatening acute exacerbation of bronchial asthma? Satu SpO2. Okay. Yes. Lagi?
Wheezing.
Okay.
The loudness of the wheezing.
Okay. Kalau life-threatening dia macam mana?
Kalau life-threatening dia silent.
Silent. Okay. Alright. Lagi? Lain pada tu?
The pulse rate.
Okay. Macam mana?
Kalau life-threatening bradycardia, tapi kalau severe more than 120.
Okay. Lagi? What else?
Is the patient able to talk?
Okay. How do you differentiate that? Mild, moderate, severe?
If in mild, patient is able to talk in sentences. If
Okay.
moderate, patient is able to talk in phrases. If severe, patient can only talk several words, but in life-threatening, patient cannot talk at all.
Okay, lagi apa lagi?
Breathlessness.
Okay, macam mana?
Severe is at rest. Mild is when walking, and moderate is when talking.
Okay, lagi?
The alertness of the patient. If mild asthma, the patient may be agitated. In moderate, the patient is usually agitated. In severe, also usually agitated, but in life-threatening, the patient is confused, coma, and drowsy.
Okay, lagi? So this question about the severity of asthma exacerbation is very important. It's very important. Okay, next, Afiq.
Um,
Apa lagi nak tanya?
how about the for the general examination, for look at the extremities if there is any finger clubbing.
Okay. Hanis, so there's no finger clubbing. Okay, alright, fine.
If there's any chest in drawing.
Chest in drawing. Okay, alright. The chest in drawing ni Ikhwan dah tanya tadi. Signs of respiratory distress. Lain, soalan lain.
Hmm. Nausea and vomiting.
Nausea and vomiting. Okay, no nausea, vomiting. Aminah.
Can we look for barrel chest? I mean, I know it's the patient is still 4 years old, but yeah, could it appear in such a young patient?
Yes, of course.
Can?
Barrel chest, increased epidiameter can even appear in newborn.
Oh,
One of the signs of babies born with MAS, for example, you can see barrel chest, increased epidiameter. So this child has no barrel chest. Okay, all right. There's so many other questions, but we're not going to go there. So again, okay, what is your provisional diagnosis and what are your differential diagnosis so far? What is your provisional diagnosis and what are your differential diagnosis? Okay, let's start from Husna again.
Okay. I would say this patient have asthma as my provisional diagnosis because the main points for asthma is the patient has the same symptom every 4 times.
Wait. Okay. Asthma diagnosis is not complete. So asthma diagnosis, you should mention exacerbation. So acute exacerbation of bronchial asthma. That is not enough. You need to tell me the severity of the exacerbation. So mild, moderate, severe, life-threatening acute exacerbation of bronchial asthma. That is still not enough. You need to tell us why is the exacerbation, what is the trigger for the exacerbation. So mild, moderate, severe, life-threatening acute exacerbation of bronchial asthma, secondary to pneumonia, secondary to pharyngitis, secondary to URTI, secondary to cold weather, secondary to cold drink, secondary to drugs, secondary to medication, secondary to dust, secondary to exertion. Secondary to kejut nampak hantu. Secondary to something. And that is still not enough. That is still not enough. You need to you dah bagi tahu okay, severity of the exacerbation, acute exacerbation of bronchial asthma, secondary to apa? That is still not enough. You still need to tell us the status of the asthma. How to tell the status of the asthma? If the asthma is a newly diagnosed asthma, so you need to tell us the status whether the asthma is intermittent asthma or persistent asthma. And persistent asthma ada mild, moderate, severe. So all this you need to read from where? Read daripada pediatric protocol. Better than pediatric protocol is you cari CPG for management of childhood asthma. Tapi yang tu lama sebab next year dia akan keluarkan yang baru. Tapi at least you baca lama punya management CPG management childhood asthma. Or better still, kalau you betul nak score, you go and read GINA guideline. GINA guideline, GINA, Global Initiative in Asthma. Dia French punya language. So GINA guideline. So everything kita based on GINA guideline. So you classify, kalau newly diagnosed, you classify into intermittent or persistent. Persistent pula ada mild, moderate, severe. Faham? Okay, kalau itu newly diagnosed. Kalau bukan newly diagnosed, kalau dah lama, dah on controller medication, how do you classify? You classify according to control. Is the asthma well controlled? Is the asthma partly controlled? Is the asthma poorly controlled? Pun sama, dia ada dia punya kriteria dia. You should read the kriteria. Okay, so macam tu cara nak buat asthma diagnosis. Okay, Husna, wanna try again?
Okay, I will try. Wait. Acute. Moderate acute exacerbation of persistent asthma, as there's a previous episode every once in a month, and it is partly controlled asthma, as previous stated by the parents. The patient did seek treatment at the clinic with nebulizer.
Yang ni bukan severity of the exacerbation. This one will be status of the asthma. Severity of the exacerbation is just about that exacerbation. You're talking about the previous attack apa semua. This will be the asthma control. Dia akan jatuh under intermittent ataupun persistent. Persistent pula mild, moderate, severe, persistent. Severity of asthma exacerbation tadi siapa tanya tadi tu? Aida sebenarnya. Kan? Based on apa? Based on SpO2, based on tachypnea, based on dia punya breath sound, based on wheezing, based on speech dia, based on dia punya, dia tak cakap tadi PEFR, based on color, based on heart rate, based on pulse. Ada pulses paradoxes tak? I hope you know what is pulses paradoxes lah. So this is how you classify asthma exacerbation severity. This, if you get patient asthma for exam, I can assure you we will ask this. And I personally have failed student because tak tahu nak classify asthma severity. If there is one disease, there are several disease yang kita nak we expect you to know in great detail. Asthma is among them. Thalassemia is among them. Dengue is one of them. So asthma, if you get me for exam in asthma, expect me to ask you even until pathophysiology. I will ask you about pathophysiology of asthma. And it's a favorite question juga dalam teori punya exam. Okay, Cik, boleh? Because except for COVID time, during normal time, most of your patients will be asthma and the asthma phenotypes. So you need to know in more detail. All right, fine. Okay, Husna is already stressed. Let's go to Nabiha.
My professional diagnosis is pneumonia.
Yeah, okay, why?
Because the child is having fever with tachypnea. He also because we can confirm the tachypnea because he has a breathing rate more than 40 he's 40 breaths per minute. And then he also went to kindergarten, so there are risks for infection. And he also present with coughing.
Okay. Okay, what are your other differential diagnosis?
Other differential diagnosis is asthma. 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 Uh, uh, the one how many differential diagnosis?
So third years, I expect 5 differential diagnoses.
Okay. Do I need to tell you the positive?
Yes, why and why not? Okay, tak apa, Nabiha fikir balik. Nabila.
As for provisional diagnosis, mine would be acute bronchiolitis.
Why?
The positive point for this is patient have fever,
Okay.
cough,
Okay.
then but the negative point would be there's no sick contact. So yes. As for differential diagnosis,
Is this the right age for acute bronchiolitis?
usually less than 1 year. 1 year old.
So, is it likely for the child to have acute bronchiolitis?
Oh, less likely.
So what is the physical finding in a child with acute bronchiolitis?
Fine crepitation.
Okay, the most common is fine crepitation. Lagi apa lagi?
What else? Wait,
Wheezing, wheezing.
Oh,
okay. So what is the physical finding that this child has?
Hyperinflated chest.
So yang acute bronchiolitis ni, what physical finding that this child has that probably relate to your diagnosis? Do you know the breath sound?
Oh, okay.
No one asks about a breath sound. No one asks about any additional sound. And that is the most important question you should have asked. Kan?
Yes.
Abdullah, provisional differential.
My provisional diagnosis would be pneumonia. The suggestive points are the child present with fever and also productive cough. But the points against it is that there's no contacts that have similar symptoms like him. Okay, that's for provisional diagnosis. For differential diagnosis, I would suggest upper respiratory tract infection because the patient have fever and also sore throat and cough.
Negative finding, negative points.
Negative points might be because there's also no contact. And okay, I think yes.
Apa lagi?
Apa lagi ya? maybe patient don't have I think that's all for upper respiratory tract infection. So the next differential diagnosis, I would suggest
Apa?
how about TB, pulmonary TB?
Why?
Because patient have fever, have productive cough, and
TB, productive cough.
kan.
Dry cough.
Dry cough.
Usually
So,
dry cough.
yes.
Fever is not important part of TB. Lagi apa?
Dyspnea, and he also have history of difficulty to sleep at night because of the dyspnea. But the points against is that, yeah, the productive cough, and also no other contact positive TB that have TB. Other differential diagnosis would be asthma, because the suggestive point is that both he have risk factor to have asthma, like major major criteria in API because of his both of his parents have asthma, and he have dyspnea, and also previous history of similar symptoms that happen every month.
Okay, all right. Let me relieve you all from your sufferings. Okay, why do I do this? Have you got a long case sessions with me? Ada tak? Tak ada. Tak pernah lagi.
Tak ada.
Okay, alright, fine.
Yeah, doctor.
Patutlah tak tahu lagi. Fine. What is the purpose of presenting a case? Where you present case, you clerk case. What is the
No
purpose of
diagnosis,
present? Huh?
To get diagnosis.
So the first objective of presenting a case is to get to your provisional diagnosis,
Yeah.
to sell your provisional diagnosis, to get to focus on your provisional diagnosis, because you manage the patient based on your provisional diagnosis. Your management will depend on the provisional diagnosis. Okay, that is the first objective of any presentation. So that is why you kena fokus, your history, your physical findings, semua kena fokus pada your provisional diagnosis. You kena confirm from your history tu, orang dengar, orang boleh tahu dah this is the provisional diagnosis. What is the second objective?
To rule out differential diagnosis.
To rule out differential diagnosis, and you need at least 5 differential diagnoses, because as as doctors, you will know that many disease present with similar symptoms, and your job as doctor is to confirm the diagnosis, rule out all the differential, and treat the patient accordingly. So you need to rule out all the differential diagnoses. The point is, you can never ask appropriate questions if you do not know what is your provisional diagnosis and what are your differential diagnoses. Sebab itu soalan-soalan tadi semua tak cukup. You haven't asked appropriate questions to actually confirm the provisional diagnosis. You haven't asked appropriate questions to actually rule out all the differential diagnoses. At least 5 differential diagnoses you need to rule out. It is never okay to not have any differential diagnosis. Mesti ada at least 5 differential diagnoses you need to rule out. Okay, so first objective is to confirm, to get to your provisional diagnosis. Second is to rule out your differential diagnosis. What is the third and fourth objective?
To look for complication.
To look for complications of the disease, because all disease has complication. Tachypnea has complication. Recession has complication. fever has complication. All diseases, all the symptoms has complication. And you need to look for those complications because you are treating the patient as a whole. So that is the, so your history kena rule, kena look for all these complications. Your physical examination can look for all the complication. Okay, all right. What is the fourth objective?
To look for complication of management.
To look for complication of the treatment. Pernah dengar Ke ada copy mana daripada orang lain? So to look for complications of the treatment. Because all treatment, everything that you do to the patient has its own complication. You do not do anything also pun ada complication. Kan? Patient tachypnea, ada wheezing, you bagi nebulization. Nebulization ada complication. That complication, you nak kena tengok, you nak kena treat. Kan? You pasang line. Pasang line ada complication. Kan? You ignore patient tachypneic rapid breathing, you ignore. That ignoring pun ada complication. You bagi fluid ada complication. You bagi paracetamol ada complication. You bagi antibiotic ada complication. Nothing in this world tak ada complication. Nothing. Minum air kosong pun ada complication. Minum air zam-zam pun ada complication. There's nothing in this world yang tak ada complication. So everything in this world ada complication. So as doctors, it's your job to look for all the possible complications and settle and tackle those complications appropriately. This is our job. So sebab itu, a good history clerking, it must cover all four elements. When you clerk patient, when you examine patient, it should cover all four elements. You need to get to your provisional diagnosis. You need to rule out at least 5 differential diagnoses. You need to look for complications of the disease. You need to look for complications of the treatment. Kan? So all these elements should ada dalam your history and also physical examination. Faham? And also subsequently in your investigation lah. Okay. Alright. I'm exhausted. Okay. I don't think I can continue anymore. Boleh dapat tak? Boleh dapat tak? So kita nak kena improve lagi ni. There's so many other discussion about this topic sebenarnya. I think it's good kalau kita arrange another session ke apa ke. If you want lah, tak apa. So I'm being quarantined, so I have the whole time in the world for me.
We just okay, doctor.
Huh?
We okay if doctor nak buat.
So get back to me. We'll see if we can squeeze in some time. Okay. All right. Any burning question before we stop? Because I really need to stop.
Doctor, I want to ask again about for the diagnosis of the asthma. Need to know of asthma control if there's treatment and the severity of if there's presence of acute exacerbation and another one.
Okay, macam ni. How can a patient with asthma present to you? Dia ada beberapa keadaan. Does the patient okay, patient can come in exacerbation. Biasanya patient kalau admitted dalam ward datang dengan exacerbation lah kan. Boleh tak patient datang hospital without exacerbation?
Boleh.
Macam mana? Patient yang datang follow up. You yang bagi appointment. So dia datang for follow up. Obviously tengah tak ada exacerbation lah time tu. Ataupun patient yang datang in your exam. So dia bukan datang dalam exacerbation. Tapi kalau patient datang dalam keadaan exacerbation, which is most admission macam tu. Kan, kalau dia tak ada exacerbation, kenapa nak kena admit? Dia admit sebab exacerbation lah kan. So dia admit sebab exacerbation, obviously you nak kena classify severity of exacerbation. You kena bagi tahu, you kena look for the cause of the exacerbation. Apa trigger of the exacerbation? Infection ke apa cause for the exacerbation. So sebab tu ya, kita kena diagnosis dia akan jadi mild, moderate, severe, life-threatening, acute exacerbation of bronchial asthma, secondary to apa? Secondary to pneumonia, secondary to UTI, secondary to pharyngitis, secondary to apa? Kan? Lepas tu tak cukup, you kena kata with underlying asma. Asma tu status dia lah. Status asma, kalau newly diagnosed asma, you classify according to intermittent or persistent asma. Persistent asma ada mild, moderate, severe persistent asma. Sebab treatment will differ. Kalau intermittent asma, you tak payah start inhale corticosteroid. Kalau dia persistent asma, you kena start inhale corticosteroid. Dia ada sedikit different bila you tengok GINA guideline and letters lah. Tapi tak apa, you tu so far kena faham. So you classify macam tu. Kalau patients yang already diagnosed asma, already on controller medication, ada dah inhale corticosteroid, ubat pump yang ni, atau ada on montelukast for example, then you classify the patients according to control of the asthma. You classify according to poorly controlled, partly controlled, or well controlled. Faham tu Karami?
Thank you, Doctor.
Okay, alright. I think that's it lah. Okay, let's end our session with tasbih kafarah and surat al-asr. Okay, if you want to continue the session, just get back to me, and then we'll discuss again. Okay, Assalamualaikum.
Assalamualaikum. Thank you, Doctor.
Doctor.
Salam, thank you.